Every single year, more than 15 million elective surgeries are performed in the United States. Not emergency procedures for life-threatening conditions. Not trauma surgery after accidents. Elective operations that patients agree to based on their doctor's recommendation. And here's what keeps me up at night. A substantial percentage of those surgeries, I would estimate between 20 and 40%, are not medically necessary. They are revenue-generating procedures that benefit the healthcare system financially while subjecting patients to unnecessary risk, permanent anatomical changes, and outcomes that are often worse than if they had done nothing at all. I am going to tell you about 5 specific surgeries that I would never do, and more importantly, that I would never allow a family member to do, unless the situation was so extreme that literally no other option existed. These are common procedures. Your doctor may have already suggested one of them. Your friends or family members may have had them done. And the surgical consent forms you sign make them sound routine, safe, and necessary. But what those consent forms don't tell you is that for each of these 5 procedures, there are non-surgical interventions that work as well or better without the risks, without the permanent changes, and without the complications that surgeons conveniently forget to mention during the consultation. Subscribe to this channel right now and hit that like button. We're building this channel on one principle: giving you the information that the healthcare system will not volunteer because there is no profit in you choosing the conservative approach. Every subscriber moves us closer to reaching people who deserve to know the full truth before they sign a surgical consent form that might change their life forever. Let me be absolutely clear about my position. Surgery has a place in medicine. When you have a ruptured appendix, you need emergency surgery. When you have a tumor that's compressing vital structures, you need it removed. When you have a compound fracture, you need orthopedic repair. I am not anti-surgery. I am anti-unnecessary surgery. And the 5 procedures I'm about to describe fall into a category that I call surgical overreach. Operations performed primarily because they generate revenue, not because they're the best option for the patient. Here's how the system works. A surgeon's income is directly tied to the number of procedures they perform. A busy orthopedic surgeon performing knee arthroscopies 5 days a week can earn $800,000 to $2 million annually. A surgeon who counsels patients on conservative management and sends them to physical therapy instead of the operating room earns a fraction of that. The financial incentive structure does not reward patient outcomes. It rewards procedural volume. So when you walk into a surgical consultation, understand that the person sitting across from you has a powerful financial motivation to recommend surgery, regardless of whether it's truly your best option. Surgery number 1, knee arthroscopy for osteoarthritis or meniscus tears in patients over 40. This is one of the most common orthopedic procedures performed in the United States, with approximately 700,000 knee arthroscopies done every year. The typical scenario goes like this. You're over 40, probably over 50, and you've developed knee pain. Maybe it started gradually. Maybe it came on after a specific incident, twisting or squatting or stepping wrong. You go to your doctor. They order an MRI. The MRI shows a meniscus tear or evidence of osteoarthritis, degenerative changes in the joint cartilage. The orthopedic surgeon tells you that the torn meniscus is catching in the joint, causing your pain, and that arthroscopic surgery to trim or repair the tear will relieve your symptoms. You sign the consent form. You have the surgery. And here's what actually happens. Multiple large-scale randomized controlled trials, the gold standard of medical evidence, have conclusively shown that knee arthroscopy for degenerative meniscus tears provides no benefit over conservative treatment. No benefit. Not slightly less benefit. Zero benefit. A landmark study published in the New England Journal of Medicine in 2013 compared patients who had arthroscopic meniscus surgery to patients who had sham surgery, a procedure where the surgeon made the incisions but didn't actually do anything inside the knee. The patients who had sham surgery improved just as much as the patients who had real surgery. Both groups improved because of the natural healing process and the physical therapy that followed, not because of the surgical intervention. Here's what surgeons don't tell you. After age 40, nearly everyone has meniscus tears visible on MRI, whether they have knee pain or not. Studies have scanned the knees of completely asymptomatic people with zero pain, and found meniscus tears in 35 to 60% of them depending on age. The tear you see on your MRI is probably not causing your pain. Your pain is coming from inflammation in the joint capsule, weakness in the muscles that stabilize your knee, or altered movement patterns that create abnormal loading on joint structures. Surgery does nothing to address any of those actual causes. But surgery does create risks. Infection risk is approximately 0.5 to 1%, which sounds small until you're the one dealing with a joint infection that requires multiple additional surgeries and months of intravenous antibiotics. Deep vein thrombosis, blood clots in the leg veins, occurs in 1 to 2% of cases and can travel to the lungs, causing potentially fatal pulmonary embolism. And here's the risk that nobody mentions: accelerated arthritis. When you remove or trim meniscus tissue, you reduce the knee's shock absorption capacity. Studies show that patients who have meniscus removal develop worse arthritis over the following 10 to 15 years compared to patients who don't have surgery. So the procedure that's supposed to help your knee actually accelerates its deterioration. What should you do instead? Conservative management, a structured physical therapy program focusing on hip and core strengthening, because knee pain is almost always related to weakness in the muscles that control hip stability. Anti-inflammatory interventions through diet modification, eliminating omega-6 seed oils and adding omega-3 rich foods. Weight reduction if you're carrying excess pounds, because every pound of body weight creates approximately 4 pounds of force on your knee joint during walking. Give this approach 12 weeks before even considering surgery. The research shows that 70 to 80% of people improve significantly with conservative treatment alone. Surgery number 2, spinal fusion for non-specific low back pain. Every year, approximately 450,000 spinal fusion surgeries are performed in the United States. This number has increased by more than 200% over the past 20 years, not because people's spines have suddenly become more damaged, but because surgical techniques have advanced and reimbursement has increased, making the procedure more profitable. The typical scenario: you have chronic low back pain that's been present for months or years. Your doctor orders an MRI. The MRI shows disc degeneration, bulging discs, maybe some facet joint arthritis, or spondylolisthesis where one vertebra has slipped slightly forward relative to the one below it. The spine surgeon tells you that your spine is unstable, that the degenerated discs are causing your pain, and that fusing the problematic vertebrae together will eliminate your symptoms. Here's the reality. Spinal fusion involves removing the disc material between 2 or more vertebrae and placing bone graft or hardware to make those vertebrae grow together into one solid bone. This eliminates motion at that spinal segment. The theory is that eliminating motion eliminates pain, but the research does not support this theory. Multiple studies comparing spinal fusion to intensive rehabilitation programs show equivalent outcomes at 1 year, 2 years, and 5 years post-intervention. The patients who had surgery and the patients who did rehabilitation programs report similar pain levels and similar functional capacity. The difference is that the surgery patients underwent major surgery with all its risks, while the rehabilitation patients did not. Let me tell you about the risks that the surgical consent forms minimize. Spinal fusion is major surgery, typically lasting 3 to 6 hours, involving significant blood loss, general anesthesia, and large incisions through back muscles. Infection rates range from 2 to 8% depending on the complexity of the fusion. Hardware failure, where the screws or rods break or come loose, occurs in 5 to 10% of cases, requiring additional surgery. Adjacent segment disease, where the vertebrae next to the fusion develop accelerated degeneration because they're now absorbing the motion that the fused segment can no longer perform, develops in 20 to 30% of patients within 10 years. And here's the outcome that should terrify you. Approximately 30 to 40% of spinal fusion patients experience no pain relief or experience pain that's worse after surgery than before. I have seen patients who went into spinal fusion surgery with manageable back pain and came out the other side with severe, intractable, life-altering pain that destroyed their ability to work, to exercise, to enjoy time with family. This condition is so common it has a name: failed back surgery syndrome. And once you have hardware in your spine and multiple fused levels, your options become extremely limited. You can't undo a fusion. What should you do instead? First, understand that disc degeneration on MRI is normal aging. By age 50, more than 80% of people have disc degeneration visible on MRI, whether they have pain or not. The degeneration is not causing your pain. Your pain is almost always coming from weak, deep core muscles, particularly the multifidus and transverse abdominis, combined with movement patterns that create repetitive strain on spinal ligaments and facet joints. A comprehensive approach includes specialized physical therapy focusing on motor control and spinal stabilization exercises, not just general stretching and strengthening. Pain neuroscience education, learning why chronic pain persists and how to retrain your nervous system's pain response. Anti-inflammatory dietary changes, and stress management, because psychological stress directly amplifies pain perception through nervous system sensitization. This approach requires 3 to 6 months of consistent effort, but it avoids the catastrophic risk of failed back surgery syndrome. Surgery number 3, hysterectomy for fibroids or heavy menstrual bleeding. Approximately 600,000 hysterectomies are performed annually in the United States. Hysterectomy means surgical removal of the uterus, and sometimes the ovaries and fallopian tubes as well. For decades, this was the standard treatment for uterine fibroids, benign tumors of the uterine muscle, and for heavy menstrual bleeding. The typical scenario: you're in your 40s and experiencing heavy periods, bleeding that soaks through pads or tampons, bleeding that lasts more than 7 days, or bleeding that causes anemia. Or you have fibroids that are causing pelvic pressure, frequent urination, or pain. Your gynecologist tells you that hysterectomy is the definitive solution. Remove the uterus and the problem is gone forever. Here's what they don't adequately explain. Hysterectomy is not a benign procedure. Even when performed laparoscopically, it carries significant risks and long-term consequences. Surgical risks include bleeding requiring transfusion in 1 to 2% of cases, injury to adjacent organs, the bladder or ureters or bowel, occurring in 1 to 3% of cases, and infection. Long-term consequences include pelvic floor dysfunction. The uterus provides structural support to the pelvic floor. When you remove it, the vaginal vault can prolapse, the bladder can drop, and bowel function can be affected. Studies show that up to 30% of women develop some degree of pelvic organ prolapse within 10 to 15 years after hysterectomy. Sexual function often deteriorates after hysterectomy. Multiple studies document decreased libido, reduced orgasmic capacity, and vaginal dryness even when the ovaries are preserved. And if the ovaries are removed during hysterectomy, which happens in approximately 50% of cases, you experience immediate surgical menopause with severe hormonal disruption, hot flashes, mood changes, cognitive effects, bone density loss, and cardiovascular risk increase. Here's the fact that should fundamentally change the conversation. For the vast majority of women with fibroids or heavy bleeding, there are multiple less invasive options that preserve the uterus and avoid the long-term complications of hysterectomy. Uterine fibroid embolization, a procedure where an interventional radiologist blocks the blood vessels feeding the fibroids, causing them to shrink, is highly effective with minimal recovery time and no removal of organs. Endometrial ablation, where the uterine lining is destroyed using heat or other energy sources, eliminates heavy bleeding in 85 to 90% of women and can be done as an outpatient procedure. Hormonal management using specific IUDs that release progestin can dramatically reduce bleeding without systemic hormonal side effects. But here's the economic reality. A hysterectomy generates $15,000 to $25,000 in revenue. Fibroid embolization generates $8,000 to $12,000, and it's performed by interventional radiologists, not gynecologists, so the gynecologist receives no income. Endometrial ablation generates $3,000 to $5,000. A hormonal IUD generates a few $100s. The financial incentive heavily favors the most invasive option. What should you do instead? If you're experiencing heavy bleeding, first rule out underlying causes: thyroid dysfunction, clotting disorders, endometrial hyperplasia, or cancer. Once those are excluded, try conservative options in order of increasing invasiveness. Hormonal IUD first. If that's ineffective or not tolerated, endometrial ablation. If you have large fibroids causing bulk symptoms, fibroid embolization. Reserve hysterectomy for cases where all other options have genuinely failed or where there is confirmed cancer. Do not let anyone tell you that hysterectomy is your only option unless you have pathologically confirmed malignancy. Surgery number 4, rotator cuff repair for degenerative tears in patients over 55. Approximately 300,000 rotator cuff repairs are performed annually in the United States. The rotator cuff is a group of 4 muscles and their tendons that stabilize your shoulder joint. As you age, these tendons undergo degenerative changes and can develop tears, just like meniscus tissue in the knee degenerates with age. The typical scenario: you're over 55, you develop shoulder pain and weakness, your doctor orders an MRI, the MRI shows a rotator cuff tear, and the orthopedic surgeon recommends arthroscopic repair to reattach the torn tendon to the bone. Here's the problem. Multiple studies scanning the shoulders of people over 60 with no shoulder pain whatsoever have found rotator cuff tears in 50 to 60% of them. These are asymptomatic tears. The tear exists but causes no symptoms. This means that the tear visible on your MRI may not be the source of your pain. Your pain is likely coming from inflammation, bursitis, or muscle imbalances around the shoulder, not from the tear itself. Research comparing surgical repair to physical therapy for degenerative rotator cuff tears shows no significant difference in outcomes at 2 years and 5 years. Both groups improve. The surgery group goes through months of post-operative rehabilitation and carries the risks of surgery. The physical therapy group avoids those risks and achieves equivalent results. Additionally, rotator cuff repair has a disturbingly high failure rate. Studies using post-operative MRI show that 20 to 40% of repaired tendons tear again within 2 years, even when patients follow all rehabilitation protocols perfectly. You undergo major surgery, months of recovery, and there's a 1 in 3 chance the repair doesn't even hold. What should you do instead? If you have a degenerative rotator cuff tear and your shoulder pain is manageable, try physical therapy focused on strengthening the remaining intact rotator cuff muscles and the scapular stabilizers, the muscles that control shoulder blade position. This approach works by improving the mechanical efficiency of the shoulder so that the remaining intact tissue can compensate for the torn portion. Studies show that 70 to 80% of patients improve significantly with this approach. Surgery should be reserved for massive tears involving multiple tendons, in patients under 55 who have failed conservative treatment, or for traumatic tears in young active individuals. Surgery number 5, gallbladder removal for gallstones in asymptomatic or minimally symptomatic patients. Approximately 750,000 cholecystectomies, surgical removal of the gallbladder, are performed annually in the United States. This makes it one of the most common surgical procedures in the country. The typical scenario: you have abdominal imaging, a CT scan or ultrasound done for some other reason, and it incidentally shows gallstones. Or you have occasional mild right upper abdominal discomfort, and testing reveals gallstones. Your surgeon tells you that gallstones can cause serious complications, that they won't go away on their own, and that removing the gallbladder is the definitive solution. Here's what you need to understand. Gallstones are extraordinarily common. By age 60, approximately 20 to 25% of adults have gallstones. The vast majority of these people, 80 to 85%, will never develop symptoms from their gallstones. They are asymptomatic. If you have asymptomatic gallstones found incidentally, your risk of developing symptoms in the future is only about 2 to 3% per year. Over 10 years, that's a 20 to 30% chance of eventually developing symptoms. This means there's a 70 to 80% chance you will never have a problem. But once you remove the gallbladder, you can't put it back. And the gallbladder serves an important function. It stores and concentrates bile, releasing it in coordinated bursts when you eat fat-containing meals. This allows efficient fat digestion. When you remove the gallbladder, bile drips continuously from your liver into your intestine. This creates several problems. First, you lose the ability to digest large fatty meals efficiently, leading to diarrhea, bloating, and fat malabsorption in 20 to 40% of patients after cholecystectomy. Second, the continuous bile drip can irritate the intestinal lining, causing chronic diarrhea that persists for years. Third, some patients develop post-cholecystectomy syndrome, persistent abdominal pain that's often worse than the original gallstone symptoms. Here's the economic driver. Gallbladder removal is a quick procedure, typically 30 to 60 minutes, with relatively low complication rates and high reimbursement. A surgeon can do 3 or 4 cholecystectomies in a morning, generating substantial revenue. Conservative management generates zero revenue, so the incentive is to remove the gallbladder preemptively, even in people who have never had symptoms or whose symptoms are minimal. What should you do instead? If you have asymptomatic gallstones, do nothing. Just having stones is not an indication for surgery. If you have mild intermittent symptoms, try dietary management first. Gallstone pain is typically triggered by fatty meals. Reduce your dietary fat intake, particularly saturated fats, and eat smaller, more frequent meals rather than large meals. This reduces gallbladder stimulation and often eliminates symptoms completely. Reserve surgery for people who have severe recurrent biliary colic, gallstone pancreatitis, cholecystitis, which is infection of the gallbladder, or bile duct obstruction. Those are clear indications for surgery. Mild indigestion after fatty foods is not. Let me tell you about Catherine, 52 years old, who came to me for a second opinion after being told she needed gallbladder surgery. She had gone to the emergency room with severe upper abdominal pain. A CT scan showed multiple small gallstones. The pain resolved after 6 hours and never returned. She felt completely normal. But the surgeon told her that because she had one episode of pain, she was at high risk for recurrent attacks and should have the gallbladder removed soon. I reviewed her imaging and her clinical history. She had one episode of severe pain, likely biliary colic from a stone temporarily blocking the cystic duct, but the stone had passed and she was now asymptomatic. I explained that her risk of recurrent symptoms was approximately 30 to 40% over the next 5 years, which meant there was a 60 to 70% chance she would never have another problem. I recommended dietary modification, reducing fat intake and avoiding large heavy meals, and watching for recurrent symptoms. She followed that advice. 5 years later, she has never had another episode of pain. She avoided unnecessary surgery and the permanent loss of an organ that serves an important digestive function. How old are you? Write it in the comments. I want to see which age group makes up the majority of our viewers because it will directly shape what I cover in future videos. Now, I need to be absolutely clear about when surgery is appropriate. If you have acute appendicitis, ruptured appendix, you need emergency surgery. If you have acute cholecystitis with fever, severe pain, and signs of infection, you need gallbladder removal. If you have a traumatic rotator cuff tear from a fall or injury in a young, active person, surgery may be the best option. If you have confirmed cancer, surgery is often essential. If conservative treatment has genuinely failed after months of appropriate effort, surgery may become necessary. What I'm telling you is that for these 5 procedures, in the majority of cases, surgery is recommended prematurely, before adequate conservative treatment has been attempted, and often in situations where the imaging findings are not actually causing the patient's symptoms. The decision to have surgery should never be made in a single consultation. You should always get a second opinion, preferably from a physician who is not a surgeon and therefore has no financial incentive to recommend surgery. You should always try appropriate conservative treatment for a reasonable duration, typically 3 to 6 months, before agreeing to an elective procedure. Subscribe to this channel if you haven't already. Hit that like button. Share this video with someone who's been told they need one of these 5 surgeries. You may have just given them information that prevents them from undergoing an unnecessary procedure that could permanently alter their body and their quality of life. The healthcare system is not designed to help you avoid surgery. It is designed to perform surgery. Surgeons are trained to operate. That is their skill, their identity, and their income source. When you consult with a surgeon, you are consulting with someone whose entire professional framework is built around procedural intervention. You cannot expect them to be objective about whether surgery is truly necessary, but you can arm yourself with information. You can understand that normal aging creates findings on MRI that look alarming but are present in most asymptomatic people. You can demand adequate trials of conservative treatment before agreeing to irreversible surgical procedures. And you can walk away from surgical consultations where the surgeon minimizes risks, dismisses non-surgical options, or pressures you to schedule surgery immediately.